And I would like to invite the next panelist if they are here. So our next session is on grief affirmation. And I would like to invite Dr. Neena Verma and Dr. Sita Naik. So Dr. Can I read the... So Dr. Sita Naik is a medical professional and educator, immunologist, who retired as professor and head of Department of Clinical Immunology at Sanjay Gandhi Postgraduate Medical Institute. She was formerly a member of governing body of the Medical Council of India and continues to write on the medical education policy of India. And Dr. Neena Verma, sorry, can you show the slide again? She is a grief and growth specialist and an appreciative inquiry through leader with international acclaim. She counsels and trains for grief affirmation and post-traumatic growth. A professionally accredited leadership and life coach, Neena is known for her niche focus on life purpose clarity, resilience, and deep growth. An author of 2 books and several articles, Neena's recent book, Grief, Growth, Grace, A Sacred Pilgrimage, is helping grievers the world over. She will speak on the topic of grief affirmation. Welcome, Dr. Neena.
Thank you.
Welcome, Dr. Sita.
Can you see me? I don't know. I'm still, yeah, I'm sure. You can see me, right? Do I have to make this full screen?
We can see you. Is Dr. Neena here?
Yeah, she's there. I saw her.
Okay. Hi.
Yeah, so I will just give a little few minutes about Neena herself and this topic. We are going to, I think I've seen the program tomorrow, also discuss various issues related to dealing with patients in difficult times. But grief itself is something that, well, when I trained as a doctor, which was too many years ago, the training method itself was very intimate. We followed our revered clinicians around the wards in sickness and health and lived with the patients even as undergraduates. And we watched them dealing with real life situations and how they dealt with it. And we had all these role models. I think medical training itself has changed over time. A lot of clinical medicine is taught in the bedside for various reasons, ethics, this, that, and the whole concept of training has changed. Society has also changed in the sense that we grew up in larger, more intimate families. We had more real life exposure to grief within the family and in the community. Today's medical graduates enter from much more intimate and smaller families, mostly, unfortunately, from urban centers, and have very much smaller experience or exposure to real life situations related to these. They have these have an implication in the sense that because of this scenario, you become a doctor and you're suddenly dealing with patients, and you yourself haven't really, I mean, of course, many individuals may have had some exposure, but the large majority of individuals are young people who haven't really dealt with these real life situations. And then they are dealing with patients, their grief, and grief is not just death. It's not the end of life situation that you deal with. There are so many other varieties of grief that doctors have to face with their patients. There is no part of the training which is addressing this. Unfortunately, that is a major lacunae. I think one of the earlier sessions, somebody did mention something about the lack of training in some of these areas. The curriculum has not evolved to look at the humane aspects and exposing students to the essential part of dealing with patients in these issues. The other thing is that it's not just the patient, yourself, the doctor, your own self as an individual, how you deal, the daily exposure to the patient has impact on you, your traumas, your grief. Do you suppress it? How do you deal with it? These are no longer hypothetical issues in which we just embrace each other. They have become fairly well established specialities with a lot of people working on it and talking on it. And I'm sure, as all of you have realized, that last 2 years has seen an explosion of discussion on the various issues related to stress and grief related issues. In this context, I had the occasion to get to know Neena because she has had vast experience in this field, 3 decades or so, in various related areas, but has specifically specialized in grief related issues after she had the personal loss of her very young son a few years ago. And she's now totally devoted her time in various academic activities related to this field. So with that, Neena, if I can ask you to take over and give your, she's going to talk, grief affirmation is, she will explain that, the difference between grief counseling and grief affirmation, and what are the technicalities of those areas. I don't think I'm really the competent person to talk on those. Neena, she's somewhere I saw her.
Good evening, everyone. So I'm kind of feeling an imposter for various reasons. One is this, I've always been hesitant to use the word doctor in front of my name, but okay, it's a well-earned PhD. Second reason to feel an imposter is because psychology is not the field where I really begin my educational, pursuit. I was a management professional, and my PhD is also in the field of organizational behavior and development. However, psychology had always been dear to my heart, and early on, I had been pursuing various professional accreditations and self-study and practice and this and that. The fact that I was working in the space of organizational psychology and leadership coaching, team coaching, systemic coaching, so that gave me an opportunity to keep skilling myself up. 2008, it was not by design, but just by chance that I forayed into grief work when one of my executive coaching assignments, the person that I was working with, it became clear to me by third or fourth session that that person had been sitting on an overload of years, not years, decades of accumulated trauma and grief from his early childhood. And I reported the matter to the organization and sought to be excused because I was not a qualified therapist. This is early 2008. And somehow 3 weeks later, they returned and they said, he's feeling some kind of comfort and trust. He wants to continue with you. Do whatever you can. And I really didn't know what could I do, because I did not have background in psychotherapy. I did not have background in grief. Of course, I was an accredited sensitivity trainer and had multiple other, applied behavioral science things with me, which I had been practicing also for several years. But grief per se and trauma per se is a very complex and layered matter. So I was hesitant, but we went on, and somehow few months down the line, the case went very well. The person felt benefited, and a few more, some referrals happened, and then within a year, I discovered a strong interest and inclination in me towards that work, and that's how the journey began. However, in 2014, as Dr. Sita Naik has mentioned, when tragedy struck me, and with my own loss, my engagement with my subject became something else, and it reached a new depth. And so since there on, I have been fully devoted to grief work. I no longer work in the organizational space. I continue to do coaching, but the niche is what Dr. Beena Bansal already mentioned. So the topic today, grief affirmation. Well, grief counseling is, of course, a very vast thing within that, grief affirmation. But grief affirmation is also a very personal thing. What really is grief? We all know it's a natural and normal response to any kind of loss. Death loss, non-death loss, and there are several non-death losses. Last 2 years, we have lost so many things. We have lost normalcy. We have lost the life that we know and we want to live. So that's also a profound loss. So many other losses. In organizations, they are denied opportunities, missed opportunities, deprived opportunities. There's organizational politics, manipulation, things like that. There's loss of your time. Dr. Tejal, I guess, was talking about the boundaries, the thing, and how another doctor had an unkind expectation on her time. So that loss of privacy, that loss of, my rejuvenation time and all of that. These are some simpler losses, or simpler in the sense that we can kind of recognize and notice them up close and personal. But then there are deeper losses. So there are ambiguous losses. You have a dear one, a loved one who's comatose for several years. Oh, there's a disappearance. This month, 30th March, I think there would be 8 years since Malaysian Airlines disappeared. And a dear friend of mine, his wife was on board. And though the fact that he's a sensitivity trainer himself and applied behavioral science professional himself, how the kind of ambiguous grief that he's been living with, when to stop waiting and when to start grieving, that's such a big question mark. Then there could be a complicated grief on account of traumatic bereavement, violent bereavement. There could be, untimely, unexpected losses like mine, and several other things even when it is expected. I do a lot of work with bereaved parents particularly, and widowed people. So bereaved parents, even when the loss is expected, and you people have a much closer, people who are working with children, know it more closely, that how it is, no amount of preparation can ever prepare a parent to lose a child. This is what we call ultimate bereavement. So that kind of grief can prolong for a long time, sometimes an entire lifetime, can remain acute and chronic for a very long time, and that can turn the grief complicated. Sometimes there could be complicated spiritual grief. So the crisis of faith is so severe and so deep and so enveloping that the person is unable to come to terms with the fact that there could still be a way to reconstruct a life view after the loss has happened. And then this something called disenfranchised grief. So some of you who are gynecologists would know that how in our society, pregnancy loss or stillbirth is still kind of considered more of a physiological event. And there is not much room and space allowed to the woman to hold her grief or allow her grief to show up. I had 3 miscarriages in between my 2 children. So I know how it was. I know it firsthand, how it was that this is a physiological event. You rest for a few days and you get over it and you get back to life. And so this is in one form of disenfranchised grief. But then there could be, relationships which were perhaps socially not sanctioned or socially not made public yet. And then there's a loss that has happened. And this person who's left behind, the bereaved, does not know what to do with their grief, where to allow, expression to their grief, where to put their grief on table and how to put their grief on table. And they could also be stigmatized deaths like death by suicide or death by substance abuse or something else, or disease like AIDS or something. So there's some kind of a stigma attached to it, and therefore people themselves bereaved people do not give themselves permission to even allow their mourning or their grief to become public. There's so much stigma to that. So that could be another way of, disenfranchising our own grief. And this is why I insist on using the word affirmation rather than coping. Coping is still like othering the grief, othering the process of grief outside of my system, which is not really the reality. Grief is an expression of love. And if love is within you, so is grief. Grief is very much a part of your being, a part of your experience, a part of your whole body, mind, heart, soul system. So Affirmation means what? Affirmation starts from acknowledging the reality, coming to terms with the reality, adapting to the post-lost life with some sense of resilience, with some sense of, saying, okay, I have will to restore, and I'm willing to say yes to life, despite this loss, with this loss. And then affirmation is also about, then stepping back and seeing how, is there a way that I could reconstruct my life view, which even if my loss does not make sense, even if I cannot make sense of my loss, is there some meaning that I can derive out of my grief at least? Is there some way that I could allow my expression of love for my deceased loved one, which is through grief? Can I allow that expression of love to have some meaning, some higher purpose, some higher calling? So in my model of growth, which is a 6 aspect or 6 phase, sovereign phases, they can happen without a chronology or in not sequentially bound. The higher level phases are, where having come to terms, having found a way to adaptively, resiliently, restore life to some extent, create a new kind of normal, and continuing to flow with life. Thereafter, then some people, for them, grief has touched them so deep that it also creates pockets for transformation. It creates pockets for meaningful reemergence in life with a higher calling, with a higher purpose. So many bereaved mothers, particularly, I have met who have taken up a cause and taken up a cause very strongly. Some of them have taken up the cause, which is kind of a legacy mission. My family, we run something which is a legacy mission for us, that my son used to be serving since he was 8 years. He used to run a pavement library all by himself for disadvantaged children. So we decided to take that forward, and now we've been setting up community libraries for several years now. And so that's the level of coming back to life with a higher purpose or a meaningful reemergence back in the life. Why grief affirmation is important and relevant for doctors and healthcare professionals. Dr. Tejal spoke so beautifully about boundaries. Having said that, and then Dr. Beena Bansal, if I remember right, also mentioned that boundaries can be porous. But then boundaries actually can be both predetermined and porous and evolving all at the same time. And no matter how neatly we organize our boundaries, the fact is the human in you cannot escape the first level impact of the trauma that you are perhaps the first point of encounter. So even before the caregiver, even before, especially in terminal situations, especially in life-threatening situations, especially with dreaded diseases, or where families kind of mentally preparing themselves and yet can never be fully prepared. And you are those who are working in emergency room roles and ICUs, etc., etc. You're the first point of encounter with trauma. That trauma is not exactly at the point of death, but pre-death. And that continues for long. I have some kind of a first-hand experience with my father, who struggled with cancer for 3.5 years, and he underwent all treatments, surgery, chemotherapy, radiation, homeopathy, Ayurvedic, everything. And so I know how our grief started way before we actually lost him. Then in the second wave, Delta wave, I nearly died. So how, things were when for the 1.5 months that I was in ICU. So that pre-death grief, the anticipatory grief, no matter how much we have experienced it, no matter how much we have felt it in our system, can never prepare us enough to actually face the grief. But the fact is that while for the family, anticipatory grief and their mourning can find some social space, personal space, familial space, they could even approach counselors or therapists. These days, more and more people are coming up and asking for help. The fact is, for doctors, they have to move from case to case. For them, there's no space and time in between to even touch the emotional effects that they have gathered, leave alone being able to what do I say, to address it, to recognize it well, to name their feelings, to be able to ask for help, So a part of your role and persona requires you to at least be stoic on the outside and in your conduct and in the way you conduct your business, even if you might be feeling some sense of vulnerability inside. Dr. Tejal has mentioned Bren Brown, immense amount of work, Bren, that Bren has done in the area of vulnerability. It's amazing. And I wonder how many of you are familiar with the work. Please do, about vulnerability and how it is so important to acknowledge. So that's the thing that I wanted to mention. Why doctors, for them, affirmation of the grief that they might be accumulating. It's not that you get personally attached to a patient, but there could be instances when you are personally involved with a particular case. That case, the nature of that case is so very important, that the nature of that case is so very significant for you at a personal or a professional level. So there could be some grief that you might be accumulating. There's a lot of trauma that your body might be accumulating, and body keeps the score, as you all as doctors know. So for your own sake, and for the sake of the fact that while you are dealing with the caregivers, there's quite a bit of emotional labor that you have to indulge in. There's compassion fatigue that you incur. So all that comes to settle in your body. And of course, there's not because 8 March is around the corner, I'm not mentioning it because of that, but I want to underline the fact that for women, somehow, it is not exactly, though of late gender boundaries are getting a little blurred, but the fact is that women have a more intuitive, more emotive, more expressive way. For them, it is not that easy as it is for men to find diversion through activity. But you doctors, your profession is such that you have to get back to activity as soon as possible. In fact, as some doctors were mentioning, that you cannot not afford to take the call. So in such a situation, how do especially the women doctors, how they create space for affirming their own pain, their own trauma, their own emotional suffering, and how they kind of recreate their emotional agency is all very, very important. It's a very vast subject. I can go on and on, but I'm mindful of the fact that we are at 5:25 already. And in the 3rd chapter of my book, I have presented a tiny 5-aspect framework for grief affirmation, which I've named Alive, because grief affirmation is about acknowledging and affirming and honoring the fact that those who are left behind are still alive. And if they're alive, their noble duty is to affirm life, to say yes to life, and to continue living life. And in continuing to live life, it is not a matter of coping or managing or fixing, but it's a matter of affirming and allowing life as it is, with my pain, along with my pain, not about moving on, but moving and flowing with life. So I will stop here. I think I've spoken more than I should have.
We can listen to you whole day, Dr. Neena. So if I can just say a few words. You've just seen a flavor of what the area that Neena works in. And you can imagine that with her own personal background and her to deal with it on a day-to-day basis with all the people she counsels is quite a challenging job. But I think that it is important that both as a theoretical concept and as for individuals for themselves, that these issues are recognized for what they are and acknowledged and internalized, so that not only the empathy for the patient sitting across the table, but for your own dealing of the day-to-day traumas that accumulate, because it's a cultural thing. I'm sorry, we have a way that somehow these things are not discussed in groups and forums. If you see American serials and TV serials, you will see that they have church groups which have discussing everything under the sun, whether it is, just not Alcoholic Anonymous. They have group discussions on every kind of stress and trauma, and grief counseling groups are so common in those societies. But for us, somehow it is, to put it on the table seems to be that you're not strong enough. But I think we need to grow out of that, especially in urban centers, because we are not living in, we are fairly isolated as families. We don't have a big support system around us of people who love us and who can carry us along. And so I think it's a very important. Thank you so much, Neena, for
this opportunity. And thank you. I'm grateful.
Yes, Beena, to you.
Yeah. I hardly have words to say something. We are all very, very thankful for addressing what we fail to address in ourselves, the trauma we undergo. I think you're right. We just push it back, present it as a defensive thing in some other form, which may actually not be the best way for a caretaker. Like, we are also caretakers in some way, and not addressing that may result in some other harm we may do to someone else. Dr. Usha, you want to join in some comment there before we move on to your topic?
I'm just so overwhelmed by Neena's, presentation, and so touched by your candor, and I think you've really touched some very important points about grief and grief affirmation. And I also think certain specialties as doctors, we don't see so much of, so much bad news or sick patients as, let's say, an oncologist would do, or, hematologist would do, or even a nephrologist. I mean, these are people who have very sick patients, and they lose patients all the time. And some specialties, I think endocrinologists, we are blessed with healthier patients.
To that, I'll just read Priyanka Padi's comment. Priyanka is a psychologist. She's doing work on resilience in type 1 diabetes patients. And she's just mentioning that. Just an additional thought, in the context of non-death losses, I find that chronic illness conditions, especially ones that are congenital or emerge in childhood, there is so much unacknowledged grief over losing the child or childhood that one could have had, and the life one could have had if the illness had not taken over one's life. Discrete traumatic events are acknowledged for causing grief, but the ongoing everyday grief of a tough life, not so much.
Yeah.
On that note, yeah.
And yes, of course, and it's not just the person-centric grief, the patient-centric grief, but the entire family is living in an atmosphere of grief, and it's an ongoing, as Priyanka ji has rightly pointed out. And then there are several other secondary losses that get added to that, and those secondary losses also trigger some kind of a grief. And yes, I mean,
I may also add there's a bit of a generational thing, because older physicians, including myself, when we were trained, we were taught to be the equanimity was emphasized, and I think as we have, times have changed, we are actually taught to be express more emotion, and actually be more open with our feelings with our patients.
I think the word to use is stoic. My generation is stoic.
I'd like to underline one thing particularly, which is more in the context of companioning through grief. And of course, I take specific sessions for that, for people who have to live with people who are in grief or in trauma. But for doctors also, I know that all that you're doing is with very good reasons and good intentions. And of course, you do not have the luxury of time to, I think Dr. Barua mentioned, to hold that silence. Even that could be a luxury, though it's a very sacred and noble gift that you could make to your patient. But as much as possible, if we could avoid the cliches and the platitudes, like move on, be brave. And sometimes we are saying things with all good intentions, but without being truly mindful of what that really would mean for the person in grief and trauma. So some statements are too hollow, and some statements are too heavy on the person in grief. bereaved parents particularly. I remember myself being told by some people, very educated people, a doctor saying that you still have one more child. Could there be something more cruel and traumatic than this, to be told to a parent who has just lost a child that you have one more child, as if something can substitute. So in our attempt and eagerness to help, let's not crowd the grievous space with platitudes and cliches. When we do not know what to say, the best thing is not to say anything. Just hold the noble silence.
Sometimes we find that I'm an oncologist, and we often see a lot of children dying in our care. And probably the only thing that we really have to offer them is maybe this was best for the child, or maybe it was time for the child to pass on. And then for them to kind of focus on something else, because as per the Indian culture that we see over here, there's a lot of lamenting and crying, and it's not, it's a lot of visual, we see a lot of visual expression of grief. I can understand that the parent is grieving, but there's a lot of visual expression of that grief, and it's not just the parent, it's the other relatives around as well who will howl and shriek, and there's a lot of that going around. And in that scenario, that's sometimes where we take recourse to these kind of platitudes that you say, that you need to be strong, you need to think of the others in the family, you need to think of your husband who's also grieving as well, or somebody who spent more time with the child than you have, or as you said, think about the other kid that you have with you. I understand that they're very, very hollow comments, but at that time, maybe that's probably the best that we can really offer them.
I think you made a very, very valid point, very pertinent point. And of course, you are encountering it on day basis. So you know how it is. And when you use the word visual expression of grief, this perhaps could also have impact on other patients and other caregivers in the hospital system. I can imagine that because I've been in those situations. I've done the organ and cornea donation counseling for several years of the potential donor family. So I know how it is and how it impacts the other families there. So while you are doing a noble duty by being sensitive as best as you can, and this is why I underline that perhaps there needs to be an intermittent layer. There needs to be a professional who will deal with this. The doctors should not be burdened with this additional responsibility. They already have a lot on their platter. And so I think there should be trained grief counselors who should be available in situations and settings like these. Because in this, there's no counseling. In this situation, there's holding of the space. There's companioning, there's shepherding. Counseling will begin when it will begin. In this situation, there's something else that needs to be done.
So in our case, we have Sachi, who actually acts as our grief counselor. She's a trained psychologist, and we often find that getting her in at those last minutes becomes really, really useful. So Sachi, how do you deal with that?
So as you said that, yes, holding space is very, very important, allowing them to express themselves or offering that setting, where they can have that privacy or that space, and being there that, yes, we acknowledge, in this moment what you are going through, and we are here with you. So I think that's when I take over.
Yes.
And as you said, that losing a child, no matter what you say or do, the grief is immense, and it's going to take its own time. But again, intervening, okay, how could we help you now? What are some things that you want to really, or, reach out to, or, we do the resource building for them in that moment.
That's the thing, at that point, perhaps the best thing is do things, the practical and the material stuff, transactional stuff, do that without noise, quietly, saying minimal words, mindfully, but do the practical stuff and get them to their homes with some respect, some comfort, some whatever, and because in hospital, there are so many other concerns which cannot be overlooked.
Absolutely. even in that moment, if we know that the child is about to, die, and if the parents are there in the final moments, making that final moment where if they have things to say to the child, or, helping them connect in that space, in that moment, while we be there as a support. So that also comes as a part of practice. And then follow-up bereavement is also, where we intervene, and we do that bit as well. And if the parents are going to require additional support, then I'm always here to, they can reach out to. So that's the part of
You're
it.
doing a great job. My personal
you.
gratitude to you.
So with that, I welcome Sachi and Ruchira to kickstart the next panel. I don't know how they do it. I am in this profession, but very consciously, I chose not to choose pediatrics. I can't hear children crying. I mean, this is something which is very difficult to cope with. So